Hello friends, I am little sorry that I got a little late while logging in. There was some technical problem. Hope I am very clearly audible and you can listen me clearly. I am very thankful to all for their so from in today's topic we are going to discuss multiple topics. We are going to first start with severe aortic stenosis with LV dysfunction. These are the few cases I have collected over the last few years. So let's start. Let's understand the morphology of aortic wall in the setting of congenital aortic stenosis. Normally, aortic wall has got three cusps and three sinuses. We are generally aware of bicuspid aortic wall. Bicuspid aortic wall is also two types. First type is bicuspid trisinusoidal aortic wall. Sorry for the delay. So bicuspid aortic wall is of two types. One is bicuspid bisinusoidal and second is bicuspid trisinusoidal. We are generally coming across bicuspid trisinusoidal aortic wall that is shown in first line where two leaflets are fused at a raphe. Bicuspid bisinusoidal there is no raphe. Then third is unicuspid wall. These again two types. When the commissures are fused at two places is unicuspid trisinusoidal or purely unicuspid wall. And a rare variety is dysplastic valve where valve is thickened, annulus is small. Understanding the natural history of aortic stenosis in utero is an important thing. Aortic stenosis is a little difficult to diagnose because we are not very used to taking aortic wall gradients. It is not part of routine diagnostic evaluation. If it is diagnosed during second trimester, there are high chances that it will be progressive lesions and it may progress into hypoplastic left heart syndrome. Gradients may be normal because there are no standardization of gradient. LV may be good size at 14-16 weeks, but as disease progresses, it may develop into severe stenosis and hypoplastic left heart. Aortic stenosis can be seen with other lesions like mitral wall anomaly, aortic arch anomaly, and VSD. Good size at 14. There is a difference in normal aortic wall Doppler test as against aortic stenosis Doppler test. We'll understand that. This is a normal aortic wall Doppler test. It is early peaking, as I shown this with these arrows. Like mitral wall anomaly. Now look at this patient. This is left ventricle, and we can appreciate flow gradient. This is not taken by C5 probe. This is taken by S5 probe. We'll understand sector probe. And look at this Doppler stress. I have drawn you. This is the Doppler stress seen with aortic stenosis. This is the Doppler stress seen with normal aortic wall. So this is a Doppler stress. Gradient is 34 mmHg. This case was around 26-27 weeks. This is the left ventricle, which is dysfunctional. Ejection fraction is around 30%. We can appreciate some endocardial fibroelastosis. This is the hyperechoic endocardium that we can appreciate. This is inferior vena cava. Inferior vena cava is not collapsed, it's a history of imminent hydrops. This is a short axis view at the level of aortic wall. The bicuspid aortic wall we can see, or it's a thickened aortic wall. Bicuspid is a little difficult to appreciate in many cases, but it's a thickened aortic wall that we can 100% comment upon. In initial lecture, we have seen a bicuspid aortic wall in a coarctation substrate. This is a color compare. Appreciate the severe mitral regurgitation. This is the mitral regurgitation. Yet this is again with the S5 cardiac probe, not with the C5 probe. LV dysfunction. Now, this is how the aortic stenosis looks like. Coming to next topic, isolated pulmonary stenosis with intact interventricular septum. Pulmonary stenosis is seen with variety of lesions like VSD or right-sided lesions. So we are just dealing with simple plain pulmonary stenosis. So mildest form may present after birth, but severe form may present in utero. In utero, just like aortic stenosis, gradient may be low in early gestation, so they can be falsely misleading. Severe extreme form of PS may have a small RV, or it can be a spectrum of pulmonary atresia intact IVS. Pulmonary wall stenosis is also sometimes associated with dysplastic or hypoplastic tricuspid wall. Is again a spectrum of pulmonary atresia intact IVS. The outcome of pulmonary stenosis is influenced by morphology of tricuspid wall and RV. If they are small, the outcome is worse. If they are good size, the outcome is good. Again, there are morphological variations in pulmonary wall. Normal wall is shown here. It is a typical tricuspid wall, but as there is a stenotic wall, it can be bicuspid, it can be occasionally unicuspid, or it can be dysplastic, or it can be annular hypoplasia. Again, pulse wave Doppler or Doppler trace show early or late peaking like aortic stenosis. Gradient can be deceptive in early gestation. It is important to evaluate tricuspid wall Z score and right ventricular cavity. Right ventricular cavity generally has three parts: inlet, mid cavity, and outlet. Mid cavity or apical trabecular portion. In cases of dysplastic pulmonary stenosis with hypoplastic right ventricle, one of the part may be absent. It can be just two part, inlet, outlet. Apical trabecular portion may be absent. All cases of suspected pulmonary stenosis should have a screening. Now, this is a pictorial depiction of how PAIVS looks. This is RA, RV, and pulmonary artery. This is pulmonary wall. The pulmonary wall is small. It is important that we make a three-dimensional picture of heart before we screen, so it makes screening easy. So now I'm discussing this case, which was around 19 weeks, 6 days, twin gestation, polyhydramnios, and the baby was continuously moving, so imaging was not very great. So still, whatever best I can see, I'm sharing with you. Now this is a four-chamber view. Most striking feature we can appreciate is a dilated right atrium with severe tricuspid regurgitation. The Doppler here is a tricuspid regurgitation Doppler. Only RA is enlarged, RV is not enlarged. Left side is normal size. This is the three vessel view. The forward flow, this is the spine. The forward flow in aorta is there, while the flow reversal in duct is there. So red flow and blue flow. So the flow reversal in duct suggests you of critical pulmonary stenosis, trivial antegrade flow, or pulmonary atresia. So it's a duct dependent pulmonary circulation. This is again an image showing, this is a little difficult to appreciate, but this is the right atrium, RV and RVOT. There is a flow acceleration across pulmonary wall. This is the aorta, short axis view of aorta. And this is the gradient across pulmonary wall, which is around 31 mmHg, very high for 19-week baby. And again, appreciate the stress. It's an inverted U or U-shaped stress. So this is a flow acceleration shown in both pulmonary wall and TR, both seen in same frame. The baby is moving a lot, so we can appreciate some. This is a TR shown in another plane, just to make an impression of severity of tricuspid regurgitation. Again, tricuspid regurgitation shown here. Another view to show tricuspid regurgitation. These images are taken with C5 probe. Some images were taken with S5 probe. If tricuspid regurgitation, which is not seen with C5 probe, are generally better seen with S5 cardiac probe. The gradient at tricuspid wall is close to 51 mmHg, suggests of hypertensive right ventricle. This is another case. This little big baby. This is a 4-chamber view. Most striking view in this is the dilated right atrium and right ventricle and small left atrium and left ventricle. So we can take it both way. Either the left side is pathological because it is small, or right side is pathological because it is big. But after understanding entire echo, we can come to conclusion that dilated side is right and that is pathological. Important thing to note is both ventricles are apex forming and there is no endocardial fibroelastosis. There is no AV wall regurgitation and cardiothoracic ratio is around 0.5. This is a short axis view. Interventricular septum is flat, suggestive of pressure overload, and dilated right ventricle suggestive of volume overload. This is a right ventricular outflow tag showing both things, forward flow with flow acceleration and pulmonary regurgitation, both seen in one plane. The trickle of flow that we can see is the PR and the forward flow is PS. Main pulmonary artery is dilated. Same in a short axis view, forward flow and flow reversal. So this is the forward flow and this is the flow reversal across pulmonary wall. Now coming to an important topic of atrioventricular septal defect. This is a big spectrum and it is associated with many varieties of cardiac anomalies. So I'm going to go in detail and I'll try to cover multiple things in this. Hope you will understand the spectrum and get acquainted with this. Now, atrioventricular septal defect is of many types. You can have two valves at same level with one or two annulus or single AV valve with a common annulus. There are 5 leaflets guarding the AV valve. AV valve regurgitation is a common feature and AVSD is associated with sinus anomalies like right isomerism, high risk of DORB, pulmonary arterial stenosis, and VA disorders. So it is important to analyze everything in AVSD. If anything else is there, always look for the associated anomalies. Syndromic diagnosis is quite common in this. So types is partial, intermediate, transitional, and complete. In Down syndrome, commonest AVSD is complete. Other varieties are not so common in Down syndrome. So this is long axis or 4-chamber view. In partial AV canal, we can see a primum ASD. There is no VSD. Two valves are there, and there is a tissue connect separating right and left AV wall. In transitional, there is a VSD but two valves. In intermediate, again two valves, large VSD, large ASD. And complete, there is a common valve with common annulus, large ASD and large VSD. This is the in-fast view. If you are sitting in the atrium and looking at the patient, this is the normal heart with a mitral valve, tricuspid valve. This is a complete AVSD with a 1, 2, 3, 4, 5 leaflet. And this is partial AVSD. This is a tongue-like tissue that connect, and this is anterior bridging, and this is posterior bridging leaflet. If they two are connected with each other, then it is AVSD, partial AVSD. Yeah, truly speaking, the AML is not cleft. It's if you take embryologically, this we talk about cleft AML. AML is not cleft. It is the two leaflet that are fused. So this is the four chamber view. Important thing we to appreciate is a large primum ASD, large inlet VSD, common AV valve or single AV valve. Just look at the image again and again that you will appreciate all the important features in this. This is the short axis view modified. All views are not very typical. Whatever is same baby's position, they are going to discuss it. This is the aortic wall arising from left ventricle. This is the right ventricle. Appreciate the morphology of AV valve. The file leaflets, not all seen very well, but we can appreciate how it is opening and closing. So very faint AVVR, very faint, difficult to appreciate, but trivial red flow seen. If you see all these images in dark, you will appreciate it better. Try to see these images in dark. Don't keep light. Just be in dark. You will appreciate these images better. So I see you can see the red flow better. This is taken with the cardiac probe S5. Just trivial AVVR. Better understanding of AV valve morphology, we can appreciate anterior bridging and posterior bridging leaflet and lateral leaflet and mitral sided alveolar leaflet. So this is how file leaflets are there. Aortic wall and opening of AV valve. Important to demonstrate drainage of pulmonary veins. So this is these are one side, this is other side, pulmonary veins draining into LA. I try to demonstrate pulmonary veins in every patient. This is, we have seen the origin of aorta. Now this is the origin of pulmonary artery from the RV. So aorta, and if you compare with that image, these are crossing to each other, another. Again, a four chamber view, just to make an impression how it looks. This image shows a wall morphology, one of the best way I can show you. There are five leaflets. These are anterior bridging, posterior bridging, lateral and tricuspid sided leaflets. And this is the sweep that I was talking about. It is important that we do sweep and see it again and again, and appreciate how atria, ventricle, and gate arteries are connected with each other. Just try to see how the gate arteries are crossing each other. The LV is giving rise to aorta, RV is giving rise to PA, and they are crossing. You can appreciate the crossing here and here. LV comes like this, and aorta comes like this. Sorry, aorta comes like this, and PA comes like this. So they are crossing each other. This is important because when we deal with DORV and DJ, we need to understand this relation. Now, second patient, more or less same. This is the first one was 28, 29 Vickers. This is 20 Vickers seen in second trimester. ASD, VSD, and common atrium. Common atrium is there is no interatrial tissue. If there is a primum ASD, there is some interatrial tissue. So there is a difference in definition. Common atrium is there is no interatrial tissue, but there are two atria. There is nothing called a single atrium. This is the origin of aorta from the LV. Just remember this relation, how the aorta is moving the red flow, and check this, the crossing, the pulmonary artery, that it's at a 90-degree to the aorta. So there are crossing. Now the sweep, again, look at the sweep, understand the relationship of atria, ventricle, gate arteries, and with respect to spine. An important thing is to note the fundic bubble. The fundic bubble comes here, LA, LV, aorta, RA, RV, and PA comes here. We can also appreciate origin of RPA and LPA from the MPA. Drainage of pulmonary veins. Again, important to show drainage of pulmonary veins, because anomalous pulmonary venous drainage in setting of AVSD points to the diagnosis of isomerism. We will cover it in some other day. I have isomerism with supracardiac, cardiac, and even infradiaphragmatic TAPVC. We will discuss it at some other point. Now, this is a partial AV canal, third case. Now, important thing to appreciate is that both AV wall, this is the left and right, both are at same level. You can appreciate pulmonary venous drainage. There is no interment. Ventricular septum is not showing any VSD. There is a primum ASD and secondum ASD. There you can see the small primum tissue, and this is the secondum tissue. Again, similar image showing primum and secondum ASD, two AV all at the same level. Morphology of leaflets. This is the LV and the mitral wall. We can appreciate the cleft here, anterior and posterior bridging leaflet, lateral leaflet, and the three leaflets of the tricuspid wall and RV. I have just drawn the image here so you can correlate this with that image and appreciate the wall morphology. In understanding congenital heart, it is important to know the morphology. Once we understand the morphology, we can make the more sense out of it. So this is a little skewed image of aorta coming from LV and the sweep. Note the fundic bubble here, then AVVA concordance and crossing gate arteries. Just see it 3-4 times. I'm running it. Try to appreciate this. So once we are establish AVVA concordance, we are sure we are not dealing with any CCTG or another anomalies. So just see it again and again, again and again. Now this is a little tricky case. It's AVSD with inlet VSD with malalignment perimembranous extension of VSD and pulmonary atresia. I'll discuss in little detail this case. There are many things to learn from this case. And I'll then justify why I'm making this diagnosis. Pulmonary atresia is not a routine finding with AVSD. AVSD generally comes with a pH physiology. So pulmonary atresia in this setting points towards some other diagnosis. Let's see. So this is the large inlet VSD with large primum ASD amounting to common atrium, just as in the last image. See it again and again. We'll appreciate the morphology. Same thing in another view. This is the primum ASD, absent intrathecal tissue, inlet VSD. This is LV and RV. There's some moderator band seen here showing RV. Now, why I'm talking about malaligned? If the great artery is committed to one ventricle, it is committed. Now, the malaligned means what? The great artery is arising from both the ventricles. So we'll just see in next images. This image, this is the interventricular septum. If we draw it, it goes between the plane of or through the plane of great artery. The great artery is on either side of that plane of IVS. So you will appreciate this in the sweep image that the plane of IVS, if extend further, it divides the great artery into two. Again, one more thing we have to understand is that there is only one great artery arising. Another great artery is not seen. So it's a AV concordance and both ventricle draining into one single great artery. Another great artery is not seen. Fundic bubble is on the same side of LV heart. Now this red dot, now we are searching for the second artery. First artery we can see in the arch is the great aortic arch giving rise to neck vessels, and we can see the red flow here. I have demonstrated with PW. It's a pulsatile flow, not a venous flow. So it's coming from the aorta. So it's a duct feeding the branch PA. So this is the forward flow in aorta and the flow reversal in that red induct. This is AV valve regurgitation. Either side of that IVS. Again, Malala and perihumerus VSD. This IVS plane, if extended, divides aorta in two planes. This go through the aorta. Aorta is not committed to one ventricle; it is committed to both the ventricle. Also, we can appreciate the morphology of AV valve, common AV valve, and leaflets here. Again, Malala and perihumerus VSD. Perihumerus and is inlet VSD. So we can appreciate both things together. We can see malal and perihumerus VSD in many things like truncus, TOF, all the things. So what's the correct diagnosis? So this is a AVSD with TOF with pulmonary atresia. AVSD and TOF both are seen with Down syndrome. AVSD with TOF is entity mainly seen with Down syndrome. Downs with TOF and AVSD are commonly seen together. So unique feature of Down syndrome. In this case, it's very easy to confuse AVSD with DORV or right isomerism. If it is with right isomerism, then generally it's with DORV. Perihumerus extension is not there. AVSD is unbalanced. Generally, LV is small. So there are some distinguishing features between two. Now coming to right isomerism, DORV in a setting of AVSD and right isomerism. So we'll discuss it, how it looks. So we are going to say complete AV canal with common atrium, large inlet VSD, bilateral SVC, no coronary sinus, IVC is anterior to aorta on right side of spine and DOR. So all these things we are going to see. So let's start. So simple image, we can, anybody with an understanding of three vessels, you can say there are three vessels seen, but only one great artery seen and two SVC, right and left SVC. This is the one SVC and this is another SVC. So the aortic arch and two SVC. Another great artery is not seen. MPA is not seen. So three vessels, we show three vessels, but the MPA is not absent. Ideally, this should have been a four vessel view. Right and left SVC with both the great arteries. So complete AV canal defect, inlet VSD, common atrium. We cannot appreciate any intra-atrial tissue. There is no intra-atrial tissue, so it's a common atrium. Inlet VSD, and it's more like a balanced AVSD. We was at same level. So this is aortic arch, and it's difficult to appreciate PA. Now this is a tricky image. If somebody shows you, somebody can say, no, this is the RPA and LPA, the red and blue flow, they are arising directly from the aorta, but it is not the case. We'll see that they are got independent origin. There is a small MPA that is seen. You just see it. They are arising posteriorly, not from posterior aspect of aorta. They are arising posteriorly from a different vessel. Okay, and this is the ascending aorta, and this is the descending aorta, and these are the branch PAs, blue and red flow. So let's look at this. This is the aorta. That is, if we extend the plane of IVS, both great arteries seem arising from the right ventricle. Aorta is from right ventricle. We can see big aorta and small right ventricle. So it's a DORV-like situation. Aorta and small pulmonary arteries suggest of pulmonary stenosis. So it a DORV, AVSD, DORV, yes. Again, morphology of AV valve, aorta, and PA from the RV, more like that. Morphology of AV valve, appreciate. Sometimes the views are skewed too, and once we are not used to seeing them, so we may not appreciate. But if you see your patient again and again, you'll appreciate the valve morphology better. Now we can demonstrate flow through both the great arteries. This is the aortic flow and the little flow going through the PA, and it coming here. Okay, and why I'm saying our PAs from RVs look at the relationship of PA with respect to interventricular septum and RV. It doesn't look coming from the LV, so it's a DORV. You can debate saying not, it is not DOR, it's a TGS, subpulmonic, VSD, and PS. Okay, but many times we don't see these kids. They are after birth due to the various reasons. So it's debated. Important thing is that there is a aortic arch and there's a flow reversal in duct. This red flow that we can see is a flow reversal in duct. See this again. This is the flow reversal in duct. It's a forward flow and flow reversal. So both things are there. It's a little unusual to see forward flow and flow reversal, but the flow reversal means the pace is critical. This baby is a PDA dependent lung circulation, or otherwise you will get a deep stenosis after birth. If PDA is not kept open with prostaglandin. Okay, now this very clearly shows the flow reversal in duct again with forward flow. This is the forward flow and flow reversal in duct. I'll show you why I'm saying it's a isomerism. The funding bubble is here, and this is the aorta, and IVC is anterior to aorta, and this is the spine. So I've just drawn here. This is the spine, this is the aorta, and this is the IVC. So that relationship is very typical of isomerism. Again, demonstration of pulmonary venous flow, both sides, blue and red flow. It's important to show that so that there is no confusion whether we are dealing with TAVVs in setting of status anomalies. We will discuss this in another lecture, but important to show this because the management is different if the TAPVC is there. Doing petition can be hazardous in these cases unless we correct TAPVC. And sweep, we can appreciate that the great artery's origin is from the right ventricle. Why I'm saying DORE? Because in this sweep it shows that way. Again, the common atrium intrathecal tissue is absent. And also note the funding bubble and cardiac apex is on the same side. So the funding bubble and cardiac apexes are on the same side. Now coming the last topic of today's presentation, truncus arteriosus, or also called as common arterial trunk. It's not so frequently seen, but okay, we do see across and have seen this diagnosis being confused with many things. Why I also tell you, because in most of these cases, we have found that the demonstration of branch PAs is difficult, and branch PAs is difficult. And in last 2-3 cases, if there is a critical PS or pulmonary atresia, and we generally see a malaligned VSD, subperivenosus below the below the semilunar wall, and it gives impression of truncus. Now that the morphology of VSD in truncus top is just the same. Just given that picture, one can easily confuse that this can be either. So important thing we need to when we deal with VSD with single AV semilunar wall is top PA, truncus, and VSD. Pulmonary attrition setting of TGA, DORV, or single ventricle. All these things we can miss them as a truncus. We cannot common arterial trunk with single ventricle also, but it's rare entity. So in truncus, by the name, branch PAs or main pulmonary artery arises from the ascending aorta, and generally branch PAs are a good size, and there is no duct and there is no flow reversal in duct. That is important thing we need to understand. So if you're not clear, try to look for duct, look for the NP origin. So let's see. This is how the truncus looks. This is the truncal wall. This is aortic arch, and this is the origin of main pulmonary artery from the posterior aspect of aorta. So every great anatomist or what to say cardiac morphologist or try to classify, understand and unpack the two biggest name under the collateral word. We can give them one prag 1, 2, 3, 4 or collateral word, whatever we are feel like. Generally, my practice is to give a anatomical description what I see, then going into classification. So whatever I see, I write in my curriculum. So I'm starting with the sweep. Now, important thing is to appreciate two AV valves, two ventricles are seen. That so we are dealing with four-chambered heart. There is a single semilunar valve, and we see something coming at posterior aspect of ascending aorta. Okay, so the quadricuspid semilunar valve is a very common finding in truncus, and this is the AV valve. This is a truncal valve. It's a lateral sweep. I'm going from one side to another, and at there you can see appreciated drainage of or origin of one of the truncal valve here. This is the arch of aortic arch and PA joining here. Just try to look it again and again. In the dark, you will appreciate the origin of MPA from the posterior aspect. Okay, now it's seen better here. So this is the arch, truncal arch or aortic arch, and this is the MPA arising directly. This is the semilunar valve. So this makes the things clear. If you want to make a diagnosis of truncus, show origin of MPA from posterior aspect or branch PAs. So this shows the flow in the PA. This is the forward flow in MPA, and this is the aortic arch. So it's important to show this anatomy. Just labeling something like top PA or as a truncus won't do. Try to show the anatomy. Just put an aqueous limit low or aqueous limit high. So bring about the flow into the things. So this is the truncal wall. So you can see right RPA and LPA here. Is the right arch. RPA is here and LPA is here. So the bifurcation is seen. RPA and LPA. This view was little grown up 28, 29 week. So I could not get very great images. Position was weird. But this is the aortic arch. This is the MPA origin from aorta. And this is the right and left PA. So thank you for your watching. Hope this presentation you find it interesting. We will come with more interesting topic next Wednesday. Thank you till the time.